Okay, and I'd like to thank Toby and the organisers for the invitation to speak here today. And I'm going to talk about transfusion triggers or thresholds for red cell transfusion. And if we could just bring up the first question slide, please. So I just asked the audience, what threshold would you transfuse a 70-year-old man undergoing laparoscopic cholecystectomy? Okay, well that's very good. That's compliant with most contemporary blood management guidelines. So obviously I can go home. I don't have to tell anyone anything. But I'll go on to my talk. And we've heard a lot about blood management, and we've heard about the two primary areas that are the focus of blood management, which are anemia and coagulopathic hemorrhage. And they're relevant to surgery because surgery, in one way or another, utilizes the vast majority of red cell and non-red cell components in the UK. Cardiac surgery uses a lot of red cells, but predominantly a lot of clotting factors. HPB, very similar. Trauma and orthopedics use a significant portion of red cells and fewer non-red cell components. But surgery is one of the major users of the 1.7 million red cells that are used in the UK every year. This is a major financial cost, and it's important that we use this resource wisely. You've seen the three pillars of patient blood management. These are now part of most blood management guidelines, most transfusion guidelines, and increasingly in health policy. But I would draw a note of caution about how much we accept as at face value for many of these guidelines. Patient blood management is a concept, it's a paradigm, and not all of it is supported by evidence. And I think there's a risk that if we introduce practice that is at odds with evidence, there's a risk that we can discredit what is otherwise a fairly good idea. And if you look at this as a systematic review of meta-analysis that looked at a whole range of different blood management interventions, and you can see that they're very effective at reducing transfusion. But if you look at their effect on clinical outcome using the same meta-analysis, you can see that most of these blood management interventions don't seem to have any benefit to patients, and in fact many of them, if you look at recombinant activated factor 7 or aprotein, for example, have actually been shown in high-quality randomized trials to harm patients. So what I would say is I think patient blood management is a good idea, but we have to be very careful that we use the evidence and high-quality evidence to form the basis for that. I'm going to talk about the anemia paradox, which everyone's familiar with, and this is a graph that could be done in cardiac surgery, orthopedic surgery, colorectal surgery, any kind of clinical setting, where basically, as patients, as they present to the anaesthetic room, as they become more progressively anemic, and we've heard from Toby how that's approximately about a third of people that come to surgery. They're usually elderly people in their 70s. And if you reverse their anemia with a red cell transfusion, you have a paradoxical increase in the adverse event that you may be trying to prevent. So this is acute kidney injury here, but it could be low cardiac output, it could be stroke, it could be myocardial infarction, it could be any measure of outcome that you care to mention. There's this consistent paradox, and if you're researching anemia, it's called the anemia paradox. If you're interested in transfusion, it's called the transfusion paradox. And our research has tried to focus on unraveling the transfusion paradox to try and understand whether or not this is actually a causal relationship or merely due to confounding, because of course this is observational data. So there are some other observational data which is sort of pretty compelling that there may be harms associated with transfusion, red cell transfusion, and this is a line on the x-axis where you've got the number of units transfused to a cohort of cardiac surgery patients, and this is the percentage of major organ injury to the three key organ systems that are affected after cardiac surgery, and they are the lung, the kidney, and the heart. And you see there's this kind of linear dose-response relationship, which many people have taken to be very supportive of the fact that red cell transfusion can be harmful. And you can do clinical experimental studies where you measure inflammatory responses in transfused and non-transfused patients. And again, you see this very consistent dose response where you get an increased inflammatory response in patients who receive transfusion. And there's a strong narrative, therefore, that transfusion is harmful. And of course, we know that there's a storage lesion where you get changes in the supernatant and accumulation of pro-inflammatory particles in the supernatant of stored red cells, and they also lose their structure and function during storage. So there's a strong narrative and a mechanistic argument as to why transfusion may be harmful. When we go to level 1 evidence, this is the Cochrane review from 2012, led by Jeff Carson, and they did a systematic review of all the randomized controlled trials that had compared a more liberal transfusion trigger or a higher hemoglobin threshold versus a more restrictive trigger or a lower hemoglobin threshold. And by and large, these thresholds are between about 7 to 8 in the restrictive arm and 9 to 10 in the liberal arm. They're all pretty consistent. And this, by a whisker, almost confirmed the data shown by the observational data that actually patients randomized to the more restrictive arm in these trials had a lower risk of death. The findings were not quite statistically significant, but there's definitely a strong signal there. On this basis, it was recommended, therefore, that because there's obviously no definite evidence of harm, but there's no clear evidence of benefit, we should adopt a more restrictive transfusion practice because obviously that's cheaper, and as we've shown here, these trials show that it has no benefit. And Jeff Cochrane also led the AABB blood management guidelines, which are the most comprehensive contemporary blood management guideline. And this restrictive trigger has been incorporated into almost all of the red blood cell transfusion guidelines. Interestingly, they also stress that you should adopt restrictive transfusion triggers for patients with cardiovascular disease. So you shouldn't transfuse people who have cardiovascular disease who have a hemoglobin of 8 or less. That seemed slightly odd to me because the trials that had been cited in the Cochrane review, only three poor quality studies had actually recruited patients with severe cardiovascular disease. Again, this restricted trigger is incorporated in almost every other blood management guideline that you care to mention, and there's definitely no blood management guideline which advocates more liberal transfusion. As I said, it's been incorporated into health policy. The front runners were the government of Western Australia, but more recently we have our own better blood transfusion guideline. There were guidance issued to trusts following an article published by NHS England last year to introduce patient blood management to the NHS. And again, there were key metrics within those guidance which stressed that lower transfusion rates would be a marker of quality, i.e. restricted transfusion is recommended. We've done a slightly more recent systematic review which confirmed the Cochrane review. This is in non-cardiac surgical trials. And we showed an overall benefit for more restrictive transfusion. So this seems to confirm this narrative that blood is bad for you. And again, if you do sensitivity analysis of this and you take out the weaker studies, this seems to be consistent. But there are lots of weaknesses in these trials. And these are important design features of randomized trials of transfusion triggers, which mean that there is a lack of certainty as to whether or not these findings are true or not. And the first thing is that typically these trials have always recruited low-risk patients. So if you have very low frequencies of adverse events in both arms of the trial, you're very unlikely to detect a difference. And this will tend to move effect estimates towards the null. Very often as well, these trials have randomized patients preoperatively, and they include significant numbers of patients in both arms of the trial who never become anemic and would never have become transfused, which again reduces the signal-to-noise ratio of the trial and tends to move the effect estimate towards the null. Only 2 of all of those trials had actually documented adherence to transfusion protocols within the trial, so we don't actually know whether or not there was any adherence to the designated protocols. Again, an important source of bias which would move effect estimates towards the null. And finally, until recently, almost none of these trials followed patients up post-discharge from hospital. So there's a major risk that important events that might have occurred post-discharge weren't picked up in these trials. And again, this would move effect estimates towards the null. So we have this wealth of level 2 evidence or observational evidence showing that blood is harmful. We have evidence from level 1 studies, predominantly in patients without cardiovascular disease, showing that blood is harmful, but with significant limitations. And we don't really have good evidence for patients with cardiovascular disease. If we looked at the cardiac surgery studies, these are the observational data here, and you can see that the effect estimates for the observational analysis show that transfusion is harmful. And to be honest, almost every observational analysis is always going to show transfusion is harmful because sicker patients are always given more blood. However, there was a slightly interesting signal when we looked at the randomized controlled trials. Admittedly, they weren't very high quality trials for the reasons which I've stated, but the signal appeared to be on the other side. And this shows that there may be a subgroup of patients, particularly patients with unstable cardiovascular disease, where restricted transfusion does not have a clear benefit. And that means that there's uncertainty as to how we should best treat these patients. I'll just move through these. And this uncertainty is reflected in wide variability. When we audited transfusion rates in UK cardiac surgery centres in 2010, we saw that transfusion rates range from about 35% to about 76% between units. And this was even after we had adjusted for baseline risk or the factors that predict transfusion. So that there's institutional and individual bias in how we transfuse patients because there's a lack of high quality evidence to guide our decision making. So we conducted this trial, the HTA-funded Titer 2 trial, which was a pragmatic trial to compare liberal versus restrictive transfusion triggers in cardiac surgery. And we tested the hypothesis based largely on the available evidence that's suggesting that transfusion is harmful, therefore restrictive transfusion would be better. Our hypothesis was that more restrictive transfusion would be beneficial to our patients. And we had 2 thresholds, 7.5 and 9, and these really represented the extremes of contemporary practice that we could incorporate into a trial design that would then be acceptable to most cardiac surgeons in the UK. And our primary outcome was a difference in postoperative infectious and ischemic complications, and we developed that endpoint on the basis of previous observational analysis that we conducted. And we looked at a range of other secondary outcomes, including death, and we did a formal cost-effectiveness analysis. And to address some of the limitations in previous trials, we made a number of very careful design modifications to the trial, and I'll talk about them a little. So it was a multi-center trial, which obviously is the highest level of evidence. It was single-blinded because we weren't able to blind doctors to the randomization allocation. We overcame detection bias by 100% data verification for all our primary outcome data. And we also assumed that there would be some gaming around the thresholds, that doctors have very strong feelings about transfusion. They know what threshold their patients need their red cell transfusion, and we anticipated that there would be not all the professionals involved in the trial would be completely compliant. So we increased the sample size by about a third to anticipate that there would be some lack of compliance. And we also had secure internet randomization, so for the trial buffs among you, that's a big deal. We undertook the trial in almost all the large tertiary cardiac centres in the UK. So this is a pragmatic trial of a pragmatic intervention. It's taken place in a representative environment, so it means that the results are immediately relevant to our patients. It was an inclusive trial. As I said, it was a pragmatic trial. Basically, if you're having heart surgery and you're an adult and you're happy to have a blood transfusion, you weren't a Jehovah's Witness, you could go in the trial. We virtually took all comers, no matter what kind of surgery they're having. We had the thresholds, as I said, but we had quite a strict transfusion protocol because it was very important to specify the exact transfusion protocol and then monitor compliance to every aspect of it. And we defined lack of compliance as either severe lack of compliance or not severe lack of compliance. And severe lack of compliance is where the doctor completely ignored the protocol. And non-severe non-compliance was where they simply ignored one step of the protocol. So it says transfuse 1 unit of red cells if the hemoglobin drops below the threshold, monitor the hemoglobin and transfuse if 1 more unit of the hemoglobin remains below the threshold after rechecking. So in other words, if you gave 2 units, that was a breach of protocol. If you gave another unit before you'd rechecked and shown it was below the threshold, that was another breach of protocol. If you waited longer than 24 hours before giving your second unit, that was another issue. So there were different kinds of breaches of protocol, but severe non-compliance is where the actual protocol was completely ignored. So we had our primary endpoint was this composite of serious infectious and ischemic events. And then we had the secondary endpoints were individual components of the primary outcome, pulmonary morbidity, quality of life, costs, and death. And we measured the process to avoid procedural bias by carefully monitoring the hemoglobin of every patient at every time it was measured during the trial to assess compliance. And monitoring every individual unit that was given. As I said, we increased the sample size. It was predicted that we need 1,500 patients, but we increased it to 2,000 patients. So we did an intention to treat analysis. And these are our results. So an important design consideration of this trial was that all patients were consented preoperatively, but they were only randomized when they became anemic. So therefore, avoiding the dilution of the effect by including large proportions of patients who would never become anemic. So therefore, we randomized 3,500 patients, but we consented 3,500 patients, but we only randomized 2,000 patients who became anemic postoperatively. And this was a postoperative intervention looking at transfusion triggers postoperatively. Now that meant that we had to detect that they become anemic and then randomize and apply the intervention. And that meant that the intervention was not fixed in time or place, and that the person responsible for the intervention could be a doctor, a nurse, a research fellow, it could be a registrar at midnight on a Saturday night on the ward. It was a complex intervention, and that was another reason why we had to be very careful about how we applied the intervention to make sure it was applied correctly. But anyway, we ended up with 1,004 in the restrictive group, 1,003 in the liberal group. 4 patients withdrew in the restrictive group, leaving 1,000 in that group and 1,003 in the liberal group. And there was almost complete follow-up for the patients in this study for 3 months post-surgery. So there was 98% completeness of follow-up for the primary outcome and 95% completeness of follow-up for all aspects of the outcome. So that's pretty remarkable. So it means that attrition bias is very unlikely to have accounted for our results. There's no cardiac surgeons here, I assume, so to show you that there was no real difference in baseline values, we've got this thing called the Euroscore, which we use to risk stratify patients in cardiac surgery, and it shows that the Euroscore was absolutely identical between the two groups. But we achieved, our randomization was successful in that we had 2 groups that were equally matched. We showed clear separation in terms of the nadir hemoglobins between the patients, so approximately 1 gram per day. And we also showed clear separation in terms of transfusion exposure. It was a post-operative intervention, so we looked at pre-randomization transfusions or transfusions in theatre, and they were equal between the 2 groups. About 25% of patients in both groups were transfused pre-randomization. But post-randomization in the restrictive group, we had about 53% transfused, and in the liberal group, we had 92% transfused. So we have very good application of the intervention, we have good separation of our hemoglobins, and we've got differences in the volume and frequency of blood that's administered to both groups. So we believe that we have applied our intervention successfully. And this is the primary outcome. So this is the results of our primary analysis of our pre-specified outcomes on the CRF, describing the components of the primary outcome. And there was no difference. So that means that we would reject our hypothesis that restrictive transfusion is better. Okay? So what we say is that in our trial it showed that transfusion was not harmful to cardiac surgery patients. And there was no difference in terms of ischemic events, and there was no difference in terms of infectious events. Now, one of the things we noticed about this data is that when we looked at acute kidney injury, the distribution of acute kidney injury was not as we would have expected, because normally you would have a large number of stage 1 acute kidney injury, a smaller proportion of stage 2, and an even smaller proportion of stage 3 because it's a pyramidal distribution. But these were equal. And when we looked at the data, we realized that there had been some inconsistency between units about how they defined acute kidney injury. Now, the CRF proportion, the primary outcome section of the CRF is sacrosanct. It can't be changed once it's completed. So the results of our primary analysis are that there's no difference. But if we took daily creatinines that were measured in every patient during their time in the trial, we got a slightly different result, and I'll show you that in a minute. We did some sensitivity analysis. If we excluded patients who had been transfused pre-randomization, the benefit moved towards a benefit for liberal patients, but it wasn't significant. If we included the acute kidney injury events using the objectively recorded creatinine data, not the CRF data of the primary outcome, we actually showed that there was a significant benefit for liberal transfusion for a revised composite primary outcome. If we, however, looked at only serious components of the primary outcome, such as cardiogenic shock, myocardial infarction, stroke, or sepsis associated with organ failure, there was absolutely no difference. Most of our practice, we influence our transfusion decisions according to the comorbidity of the patients, their age, lung disease, kidney disease, left ventricular function, and so on. And we looked at the interaction between those preoperative factors and the overall effect estimate, and we showed that actually none of these risk factors interacted with the overall effect estimate. So the effect estimate that we're measuring didn't seem to be influenced by age, lung disease, kidney disease, and so on, which is an interesting observation. When we came to our other secondary outcomes, we looked at death, however, we found that fewer patients in the liberal group had died, suggesting a survival benefit for more liberal transfusion. Of course, this is a secondary outcome, so the study wasn't designed to detect a difference in this, and one of the limitations of secondary outcomes is because they're not measured in the same way as primary outcomes, there's an assumption that there may be bias in how they're detected. But of course, death's a pretty robust outcome. It's pretty resistant to that kind of bias. We looked at the interaction between severe non-compliance and the overall effect estimate, stratified by the different units involved, and there was no interaction between protocol non-compliance and our overall effect estimate, which makes us more confident that what we're measuring is not due to non-compliance or gaming by doctors within the trial. So our main findings were therefore that restrictive transfusion was not beneficial in a large pragmatic trial of restrictive versus liberal transfusion thresholds in cardiac surgery. There was no difference for the primary outcome or serious elements of the primary outcome, but there were the findings of secondary analysis and secondary outcomes that potentially have led us to a new hypothesis that maybe actually liberal transfusion may be beneficial. Of course, you have to stress that it hasn't been proven by this trial. So, as I said, there were a number of important design aspects of this trial that we put in specifically to address limitations we'd identified in previous trials and to try and really find out what we felt was the real effect, the truth, as it were. So it was a very pragmatic trial. It was a pragmatic intervention, which is a complex intervention, undertaken in patients, cardiac surgery patients in their generality in the UK, so it's relevant for our patients. We showed clear implementation of the protocols with separation of patients in terms of their lowest hemoglobin and their transfusion exposure. We had very careful follow-up and objective data validation for all our primary outcome values, and all our other endpoints were verified by blinded personnel. There are limitations that it was a single blinded study. There's always the possibility that some sort of gaming or procedural bias may have entered into the trial, although we think that's unlikely because we took steps to counter that. And of course, we have slightly inconsistent findings in the trial, in that we find a difference in death, but we don't find a significant difference in sepsis or infectious or ischemic mortality, which sort of, there's no sort of strong narrative there, and we acknowledge that. If, however, we go back to our cardiac surgery randomized trials and put our Titer 2 data into our previous trials, again, that shows a consistent benefit in favor of more liberal transfusion. That effect just touches the line of no effect. So we would have to conclude that even the systematic review does not show a clear benefit for liberal transfusion. But one hypothesis is that patients who have severe symptomatic cardiovascular disease, and you don't undergo cardiac surgery unless you've got severe symptomatic cardiac disease, because that's the class 1 indication, that perhaps in these patients they don't benefit from restricted transfusion. Perhaps they need higher hemoglobins, and we found from the Tour de France that people who are at the extreme limits of their physiological reserve do benefit from higher hemoglobins and blood transfusions. And if we test that hypothesis, going back to our original systematic review, and we stratify patients according to whether or not they've got active or symptomatic cardiovascular disease, stable cardiovascular disease, or they excluded cardiac disease, we see a different finding. We see that in patients with unstable or severe symptomatic cardiac disease, more liberal transfusion appears to be beneficial, appears to reduce mortality. Whereas there's still some residual uncertainty about stable cardiac disease in patients with no cardiac disease. So my conclusion, therefore, is that restrictive thresholds are safe in patients without symptomatic cardiac disease. I believe, although the evidence doesn't 100% support that restrictive is worse than liberal in cardiac surgery. And that unstable cardiovascular disease may represent a specific high-risk group, and that patients with limited cardiovascular reserve who've undergone cardiopulmonary bypass or of oxygen supply dependency may benefit from higher hemoglobins. And that we can't assume that Cochrane reviews that group patients with cardiac and non-cardiac disease are applicable to all our patients. And finally, I would say that we should never, ever base any treatment decisions on the basis of an observational study. So if I go to the final question of the second question for my talk, please. So this is a slightly different scenario to before. So what threshold would you transfuse a patient undergoing above-knee amputation with a history of recent myocardial infarction, i.e. within the preceding 5 days? Yeah, well, there you go. So you've been listening. Thank you very much indeed.